Top Med Talk.
Nick Geriatrician here. Welcome to Top Med Talk. It's a conference highlight and it's presented by Dr. Jugdeep Dhesi, clinical lead, POPs and consultant geriatrician at Guy's and St Thomas's NHS Foundation Trust. Have a listen. It's called Detecting and Managing Frailty.
So, detecting and managing frailty. So frailty has been pretty topical in geriatric medicine for kind of 20, 30 years really. But what's been kind of interesting is how it suddenly now started appearing in the surgical and the anaesthetic literature, probably over the last 10 years or so. And that's not really surprising, is it? Because, of course, frailty, we know, is related to ageing. It's not solely associated with ageing, but it's certainly related to it. And, of course, we know that the surgical population is ageing. And that's because the majority of our major and complex surgical procedures are conducted for neoplastic disease, for degenerative disease, such as osteoarthritis, for metabolic conditions, such as vascular conditions requiring peripheral arterial disease. And all of those conditions increase in incidence, prevalence as people get older. And when we look at the national audit data, so from NELA or from the National Hip Fracture Database, again we see that the majority of these kinds of major procedures are conducted within the older population. So what is frailty? You know, it's this word which kind of gets chucked out there quite a lot, and we all kind of think that we know what it means. There's no kind of agreed, internationally accepted definition still for frailty. But the British Geriatric Society, in their Fit for Frailty document, describe it as a distinctive health state, which is related to ageing, in which multiple body systems gradually lose their inbuilt reserve. And it's such that, kind of shown here in the diagram, that as age goes up, we start to lose our physiological reserves, such that this person becomes a bit more vulnerable to minor external stresses. So if any of us ended up having a change in our medications or a minor infection, a fall, then we may well dip a little bit in terms of our ability to be able to manage, but we'd recover pretty quickly back up to the same baseline at which we were previously. In comparison, if patients are frail, then they're more likely to dip lower, take longer to recover, and may well not recover back to the level at which they started, sometimes leaving them with greater dependency at the end of that. And really, there are two different paradigms in the academic literature which are often used to conceptualise frailty. We've got the frailty index and then the frailty phenotype, both of which have come from North America based on large national data sets. So the frailty index, really what it does is it describes the number of deficits which are accrued across multiple domains. And those domains kind of relate to physiological change, pathological insult, psychosocial change, and encompass a whole load of symptoms, signs, investigations. And what that allows you to do is to really calculate the number of deficits which have been accrued across those multiple domains, allowing you to count those and then calculate a frailty index. In comparison, the frailty phenotype describes the physical characteristics related to the frailty syndrome. So it really splits out into the 5 criteria which are listed there on the left. And those then are related to the outcomes such as falls, worse mobility, hospitalisation and death. And it's the phenotype which often gets described more so in the literature than the index model. So in the context of all of that, does frailty actually matter to the audience here? So one of the first papers came from the Macquarie group, where they showed that if you added in a frailty score, and in this instance they used something that was based on the frailty phenotype, that you could increase the predictive power of ASA in terms of predicting post-operative complications and discharge to an institution. And since this paper's been published, there have been numerous other studies describing the association of frailty with post-operative outcomes. And really, when we put all of these studies together, what they show is that frailty is associated with an increase in 30-day morbidity, mortality, and an increase in things like length of stay. So that's 30 days, but then there's been more recent work done by the McIsaac group over in the States, really looking at what happens to these frailer individuals over the year post-major GI, urological and vascular surgery. And again showing that frailty predicts 30-day mortality, but is also associated with a higher mortality at a year. Further systematic reviews, so loads of papers which constantly come out telling us that frailty is common and it's bad. So you're kind of left with, okay, so this is, not good. Sick people die. And, so what do we actually do with this? And what kind of it leads us to think is, well, maybe we ought to be screening, case finding, and then treating people with frailty within this setting. So if we think about that a little bit more, there's loads and loads of tools out there. So everybody seems to come out with yet another tool to be able to describe frailty, whether that's a measure or a score, whether they're using surrogate markers such as grip strength or walking speed, developing scales and scores such as the Edmonton Frail Scale, different biomarkers constantly being tested, and then people developing their own tools to use within their own setting, whether that's disease-specific or whether that's surgery-specific scores. And the problem with all of that is that all of the systematic reviews that constantly look at all of these different scores and things tell us that we can't endorse one above the other. And that's kind of particularly kind of unhelpful when we're trying to translate this into our clinical settings. But the reason why they say this is because we've been testing all of these scores and measures and so on within specific populations, and then starting to try to think about whether they're reliable, valid, responsive within specific populations. And then added into that, we've got the issue around the clinical feasibility of using them. How long does it take to do these scores? Can we actually do them in pre-op assessment clinics or in the ward setting? How do we get people kind of able to do these scores in a reliable, consistent manner? And so the latest papers still tell us that there's no consensus on which one we should be using. So what do we as clinicians do with this? We're seeing patients in emergency settings, we're seeing them in very elective settings, and then we're seeing them in those urgent planned settings, the cancer pathways. So how do we start to translate this into what we're doing day to day? So we've got gait speed, which actually at a gait speed of less than 0.8 meters per second is particularly sensitive enough for picking up frailty, but it's not specific. So, it's very good. It's kind of saying it's likely that someone's frail. But of course, if any of us ended up falling over, breaking our legs, then of course we'd have a slow gait speed. But that doesn't mean that people are frail. We've got the clinical frailty scale, which is becoming very popular because it's a nice picture. So people can just ring the picture when they see people in their clinic setting. But actually the difference between being kind of vulnerable but not dependent, and then being moderately frail, actually, it's pretty hard to discriminate between those. If someone's got a lower respiratory tract infection, they may suddenly get down to this stage, but within 3 or 4 days be back up here again. So how do we, again, translate that? We've got other scores like the Edmonton Frail Scale, which map onto the domains which are characteristic of the frailty syndrome. And so they're helpful in terms of the fact that they help us to be able to work out what issues are contributing to the patient's frailty. Is it their cognition, or is it issues around functional performance or social support? So it helps us start to pick out the areas where people may be having difficulties. And we know that the EFS takes about 5 minutes to do in a clinical setting. It can be done by trained volunteers. It is consistent. There's good inter-rater reliability. And then more recently in the UK, people will be hearing about the Electronic Frailty Index. So this is a score which has been developed by Clegg and colleagues up at Leeds and Bradford using a very large data sets. And this is now coming into play in primary care. So many of you, kind of in your local areas, your GPs will be using the Electronic Frailty Index to start to identify patients who are frail or in the pre-frail group for whom they're starting to put interventions in. So this is likely to become what's being used in primary care. So I think if we're going to take all of that, we do need to go away with something that we're going to actually translate into our day-to-day practice. Now, this is our local interpretation of what we should be doing. It's not, there are going to be variations on this and, different people are going to choose to do different things. But this is essentially what's being done by most geriatricians who are involved in perioperative care around the country. So from primary care, they're trying to get the EFI in the localities where they work because that gives them a good idea of where people are at. For the elective setting, then gait speed, the Clinical Frailty Index, or the EFS are the ones which are being used by most groups. And then the emergency setting, in the absence of anything better, people are sticking with the CFS and the EFS. So that's generally what people are doing out there. But say that we've screened and we've diagnosed frailty, well, what kind of then? And if we look at any of the WHO criteria around screening, we know that for a screening tool to actually be useful, it has to fulfill the Wilson's criteria. And certainly frailty fulfills most of these, apart from the fact that a treatment should be available. So is there a treatment for frailty? So when we're looking at treatments for frailty, what's ended up happening is that people have started to look at the interface of frailty with other conditions. So we know that there's a very big overlap between frailty, comorbidity, disability. We know that there's an overlap between frailty, cachexia, and sarcopenia. So it's no wonder that when people are looking for single interventions to address frailty, then people have started to look at exercise and say, well, exercise should work because it should address some of those aspects contributing to frailty, the comorbidities, the sarcopenia. And so there's a good underlying theoretical basis for why it may work. And there are some small studies starting to show that there may be impact of exercise on frailty, but nothing very conclusive, really. And lots of questions around this still remain unanswered. What kind of exercise? Are we looking at muscle strength, endurance, improving physiological aspects? How long do we need to train people to be able to address the underlying syndrome of frailty, which has accrued over many years? How does that actually impact on long-term outcomes? And then alongside that, all of the issues around, do people actually want to exercise? How do we start to change behaviour? So the other single intervention, which is often looked at with nutrition, with frailty, is nutrition. So again, because of that overlap between frailty and cachexia and sarcopenia, it kind of starts to make sense that you may well want to look at nutrition. And I think before you think about nutrition and frailty, it's really important to recognise the importance of this curve, really, which when we traditionally think about frailty, we often think about patients like this, kind of thin, wasted, cachectic. But actually, when we look at the frailty syndrome, we see that there is a U-shaped curve and that people with a higher BMI are also likely to be frail. And that, again, isn't particularly surprising when we sit down and think about it, because, of course, people who are overweight are less likely to be physically active. They're more likely to have a pro-inflammatory state, which can also then be contributing to that underlying frailty syndrome. But of course, you need to take that into account when we're starting to look at nutritional interventions for frailty. So again, there aren't any clear answers around using nutrition to address frailty. There's some weak evidence for protein supplementation. There's some weak evidence for vitamin D supplementation. But if we're looking at the end point of frailty, then there isn't any conclusive evidence. And then people have been looking for single agents that might start to address this concept of frailty. Is there a magic drug which we can use? But again, really, there's nothing out there that's come up with anything particularly meaningful so far. And I think what we really need to do at that point is to go back to thinking about what frailty actually is. And I think the really important thing here is the fact that it's multiple body systems which are being affected by this syndrome. It's not about finding that single one thing which is going to address that syndrome of frailty. And so that really leads us on to thinking, well, it requires a multidisciplinary, holistic, multi-domain assessment of an individual, which we can then use to identify the issues that that individual has, come up with a targeted intervention plan for the individual, addressing their needs and wants along the pathway. And that, of course, for geriatricians leads us back, as it always does, to comprehensive geriatric assessment, which is a methodology that we use within geriatric medicine in lots of different settings, community, medical inpatients, and now increasingly within the perioperative setting. And we know that when we've looked at this within the medical and the community setting, we know that applying CGA results in a 30% higher chance of being alive and in your own home at up to 18 months, with a number needed to treat of 13, so pretty low numbers. But for that to work, it has to be targeted, it has to use objective tools. We need to make sure it's multi-domain, and it needs to have follow-through. It's not about applying a single thing at one point in time. So it looks like we should be using CGA and optimization in the perioperative period to be addressing the syndrome of frailty. We should be screening and then allowing targeted multi-domain, multidisciplinary assessment. We should be using objective tools to evaluate patients across their frailty syndrome, but then other things which are contributing to the frailty syndrome, including cognition, their psychosocial issues, their medical morbidity, and then using an evidence-based methods to address those components. So, kind of for Jim, what does that look like? So Jim could be somebody that we're seeing as an emergency patient, or it could be somebody that we're seeing as an elective patient. So if it's as an emergency patient, he could have come in with his second acute urinary retention episode, 2 clot retention, likely BPH, kind of likely to need a TURP to prevent this happening again. And if we do screen using any of those tools, well, he's likely to have a low gait speed, he could have a CFS anywhere between 4 and 6, a high EFS, or you could use other methods of identifying this patient, such as talking to the nurses who tell you that he can't get out of bed. So any of those kinds of things can trigger you to think, actually, this patient needs a bit more of an assessment rather than just looking at his prostate. So if we're then going to apply an evidence-based approach, and so this is a patient that we saw just a couple of weeks ago, went to see him because the nurses told us that he had difficulty getting out of bed. We hadn't used any of those screening tools objectively, but actually he did have a slow gait speed, he had falls, constipation, and he had undiagnosed Parkinson's disease. And so then, of course, you need to apply the evidence base around how to best manage that in terms of the condition itself, the associated issues around bone health, addressing falls and balance, using those multidisciplinary interventions, finding out that another reason why he couldn't get out of bed was that he was breathless and he had decompensated ischemic cardiac failure. So getting him onto the appropriate medications, but also thinking about those appropriate medications because of the fact that he's got Parkinson's. We're not going to use all of the drugs that normally the cardiologist would be using because he's at high risk of getting postural hypotension and falling over as a result of that. So trying to use the evidence base, but tailoring it to that individual. And then nutrition, of course, he's not been getting out to be able to get his food because he can't walk properly. So getting the OT's input, physios, dietitians to start to address those components of his frailty syndrome. And then that's what helps us to inform that shared decision making kind of really thinking about whether a TURP is the right thing for this patient. What are the chances of him being catheter-free at a year down the line, when we know that actually TURPs in functionally dependent patients, only 30% of them still have a catheter at a year. So, what are we actually trying to achieve here, and what are the other options for him? And coming to a shared decision with the patient around that. Having a planned approach to the anticipated complications if he does have his TURP. The risk of him having postural hypotension, falls, delirium, making sure that we're planning for those and addressing them. And underpinning that with evidence-based approaches throughout the pathway. So, in summary, I think, the surgical population is clearly changing, and the impact of frailty is well recognised. I don't think we need any more studies to tell us that frailty is bad for us. I think what we ought to be doing is to be having a consistent approach to screening, diagnosing, and then modifying the frailty syndrome to really help to objectively and individually describe patients' perioperative risk, using that for shared decision-making, planning the pathway, and improving outcomes for this particularly vulnerable but increasing population that we're starting to see. And then we need to use that when we're looking at the case mix of our patients coming in, and we're looking at our research programs looking into the future. Thank you.
Nick Geriatrician here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com, and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.